Good evening, everybody. Thank you for joining the virtual Ask the Expert series, Hip Replacements in 2025, Stronger Outcomes Through Innovation. We're going to be joined today by Dr. Lingamfelter and actually two nurse navigators. My name is Kevin John. I'm Marketing Manager for Inova Sports Medicine Orthopedics Department. And I'll be monitoring the Q&A section and assisting with some of the interactive portions of today's program, but also helping to respond with any non-medical questions. I will leave medical questions to Dr. Lingamfelter and our wonderful nurse navigators. Before we get started, I'm going to just wait about 3 more minutes, but we can go over some light housekeeping items because we've actually got a lot of folks already in, so I don't want to waste too much time here. First, all attendees, you are muted and your video is off, but please note, the webinar is being recorded, will be sent to everyone, and you can still interact in a multitude of ways. So for the first part, we do have 2 ways you can interact. We're going to try to only use one today. If you could please limit your questions to the Q&A that's on the bottom portion of your Zoom screen, the Q&A section. That's easy for us because we can kind of answer questions in there, delete them, move them, and see them a little bit easier. So please use that. Just a reminder, this is an informative talk only, not intended to replace your own physician's advice. In order to protect your privacy and ensure you receive a thoughtful response, we suggest that you discuss the specifics of your medical condition with your personal physician. So keep it a little bit vague, but please feel free to ask all the questions of Dr. Lingamfelter tonight about hip replacements. And if you're here and you're like, well, I'm also thinking about a knee replacement, Dr. Lingamfelter can answer those as well. So feel free to put those in the chat. Just note that this is more of a knee question, but tonight will be all about hip replacements. We are lucky tonight, as I mentioned earlier, to be joined by 2 wonderful nurse navigators, Brittany Smith and Ramina Black. They will be answering questions and chiming in. I can go to little specifics about them, but why don't you 2 introduce yourselves and tell the crowd a little bit about what you guys do?
Sure. So my name is Brittany. I'm the Fair Oaks Nurse Navigator for Joint Replacements. Really just our role is to guide patients through this process. It can be a lot and a little bit overwhelming. So just sending forms of education through my chart or email, educational videos, just here's an extra resource for you if you have any questions, and then making sure you have everything arranged for yourself after surgery as well.
Ramina, anything you wanted to add?
No, just happy to help anybody along the process from, the outpatient appointment at the physician's office with Dr. Lingamfelter, to your post-op concerns, if you have any. We're happy to help.
Yeah, and I think both of them are actually not even stating some of the more amazing things to do. We have, quizzes and other educational things. They really track patients, but they also look out for outcomes, and they make sure that we stay top notch. And that's how we, have some Joint Commission, I guess, not awards, but ribbons. I don't know what they do. Gold seals, I think. Is that right? Certifications. Thank you. Again, I don't do that stuff, but our wonderful nurse navigators do, and they stay on top of that, which, we're really proud of here at Inova. So, without further ado, let me do a quick introduction. Joining us tonight is the incredibly talented Dr. Max Lingamfelter, one of my favorites, an orthopedic surgeon, board certified in orthopedic surgery, specializing in hip and knee reconstruction, total joint replacement. He had joined Inova, it feels like a long time ago, but just in 2024. And has been practicing since at least 2015. His clinical areas of interest include robotic joint replacement and direct anterior hip replacement, as well as complex and challenging revision cases. His latest accomplishment involves incorporating AI into the surgical process to enhance accuracy and improve patient outcomes by utilizing a computer model trained on over 1 million joint replacement cases. I'll let him go into more details on that. It's really amazing. He enjoys working together with patients who are motivated by the desire to rebuild their mobility and independence after arthritis has eroded their quality of life. Dr. Lingamfelter, thank you so much, and the floor is all yours.
Awesome. Thank you so much, Kevin, and thank you, Brittany and Ramina, for giving up your time right now. We really, really appreciate it. And like Kevin said, you guys are are dream makers and wish makers, and you really just, you really matter a lot where the rubber hits the road for our patients. So I can't thank you enough. And we're just beyond lucky to have such a wonderful team for our joint replacement patients here at Inova. So I'm going to share my screen here, hopefully. Share. Let me start. Let me go over to that PowerPoint real quick. And we'll do play from start. Then let me go back here. Click share. There. Can you guys see my screen now?
We are. Yep.
Okay, perfect. I'll minimize this. This is just a little intro video I'm working on. So Kevin already did the introduction. I'm a joint replacement surgeon from Northern Virginia. I grew up in Houston, but I live in Northern Virginia and work at Inova, and I'm very, very lucky to be there. This is our contact information if you want to let us know. We are happy to help for any joint replacement needs, hip or knee arthritis, and we'll go more into details here. So like Kevin already did the introduction, I'm fellowship trained, board certified in joint replacement specifically, focusing on robotics and AI-assisted surgery, minimally invasive surgery, direct anterior hip replacement. Those are some of my favorites. Also, partial knee replacement, total knee replacement, uni arthroplasty, where you just replace the middle or inside of the knee, as well as patellofemoral joint replacement, which is a partial knee replacement of the kneecap. Also focusing on accelerated recovery protocols or ERAS protocols, things like same-day surgery, so our patients can basically get back to doing what they love the most. I began my career at University of Houston in biomedical engineering, part of the honors college there. Had a great time. I got my doctorate from University of North Texas in Fort Worth, TCOM. My residency was at Rowan University and Spirit Health Network campus, just south of Philadelphia. We covered from Philly all the way down to Atlantic City at many different institutions I was fortunate enough to work with. One of the most kind of popular, or my favorite really, was the Rothman Institute, which is widely recognized as one of the top joint replacement centers in the country. I spent about 10 months there and I learned a lot and I really enjoyed it. I finished out my training with a fellowship year at University of Minnesota, focusing on joint replacement, where we saw all the most, latest and greatest techniques, cutting edge technology, and also just the most complicated joint replacements you could possibly see. And it was great. I loved it. Our areas of clinical expertise include arthritis, pain of the hip and knee, including conservative management like injections, medication, physical therapy, as well as obviously surgical treatment. We also treat meniscal injuries that require total knee replacement, labral tears of the hip requiring total hip arthroplasty, avascular necrosis, which is a disease affecting the ball and socket, and also, like Kevin said, failed prior hip or knee replacements performed elsewhere but still need some attention or fixing. Happy to help with that as well. Things that are outside of our focus would be things like low back pain, lumbar spine pathology, foot and ankle conditions, conditions related to your hand, your shoulder, your elbow, or isolated meniscal or labral injuries, which are soft tissue injuries of the hip or knee that don't require joint replacement. So things like arthroscopy. But we do have subspecialty trained partners in all of these areas. Happy to see any patient, and initiate the preliminary treatment, start the workup, and then if needed, put you in touch with our subspecialty partners who are more than happy to carry your care definitively for any of these conditions. So patients ask me what stimulated your interest in orthopedic surgery. I was a biomedical engineering student. I got the privilege of going into the operating room with an orthopedic surgeon, and I thought it was the coolest thing I'd ever seen. And I just knew that was it for me. I had to do that. So from then on, that was my mission. When patients ask me, why do you focus just on joint replacement? Well, I can still remember the morning I was rounding at a particular community hospital on the joint replacement for, and it was the day following I had helped many joint replacement patients undergo their surgery, and we were checking on them the next morning. And I remember this one woman that stopped me, and she just was so appreciative that we had fixed her hip, because she told me that was the first night she had slept in 8 years without being woken up by this pain in her groin from her hip and the ball and socket joint rubbing together. So I just remember how appreciative she was, and from that moment on, I was like, I basically have to do this, and there's nothing else that I would enjoy more. How many joint replacements do I do in a given year? So I'm very lucky. I get to do only what I love, which is hip and knee replacement, and I do about 300 to 400 a year. What do I do in my free time to kind of recharge when I'm not focusing on my patients? So I spend time with my family. I like to exercise. I like to hike. I like to hunt. I like to read science fiction novels and ride my bike or lift weights. What excites me the most about the future of joint replacement is the tremendous improvements that will come from just further research, further development of the treatment protocols, the post-operative recovery, basically how we can make the surgery easier for the patient and then also the recovery easier for the patient so they can get back to doing what they love even faster. So now to the topic at hand, arthritis of the hip. So to first understand what arthritis is, you need to understand what cartilage is. Cartilage is the soft, bouncy coating that protects the ball from the socket, basically. So this is what a normal hip x-ray looks like. Let me see if I could get a pointer here. Pointer options, laser. So right here between the ball and socket, that's where the cartilage lives, and it's a buffer. Think of it like the tread on your tire. It protects the ball and the ball from the socket, allows the ball to rotate inside of the socket without any pain, without any friction. That's under normal circumstances. So what is arthritis? Arthritis is, in order to understand that, you need to understand what cartilage is. This is a clinical diagram. This is real cartilage on the end of the bone. You can see that it's kind of fluffy, white, and it's basically a padding on the very end of the bone that allows that bone to pivot on another bone. Here's a cross-sectional image that shows you basically this cartilage has worn thin, and it's a very thin outer coating on that particular end of the bone that protects the kind of spongy, rough surface underneath. So arthritis really is cartilage loss. When that tread on the tire wears thin, through normal wear and tear, through traumatic injury, through misaligned joint, through prior surgical repair, like a labral tear or prior surgery, that results in arthritis. Arthritis looks like this. So instead of that soft, bouncy coating that is protecting that bone, this has worn down to nothing. This is exposed bone. This is more deeper exposed bone. This is a real picture of an arthritic hip, and you can see why would it be so painful, because this bone is literally exposed and rubbing on the other bone, and that's why we have to fix it. So here's an example of mild arthritis of the hip. Basically, there's still maintained joint space. There's a little bit of cystic formation. That cartilage layer is becoming thin, but it's not gone. And little cysts and bone spurs are starting to develop throughout the hip. Here's an example of moderate arthritis where that tread on the tire is wearing thinner, but the bones aren't really touching each other just yet. They're coming closer to each other. And here's really severe arthritis where the bone is rubbing on the other bone. So the ball is rubbing on the socket, and this is what we call severe arthritis. So quickly again, here's mild with lots of space, here's moderate with very minimal space, and here's severe with no space remaining at all. It can also be seen on MRI. So this is an example of a normal MRI where the bone is black and solid and healthy, and you can see that it's a uniform appearance all the way from the ball into the femur, all the way up into the cup or the acetabular bone. Everything looks healthy and uniform. And then the cartilage looks like this kind of gray icing on the cake. It's the layer insulating the ball from the socket. Here's what arthritis looks like under an MRI. You can see that that bone has become bruised and damaged. There's lots of cystic and sclerotic changes. This white material is actually edema. That's fluid inside of the bone that has gotten there because the bone has become bruised and damaged from the arthritis process. That ball is rubbing on the socket. There is no cartilage left or remaining whatsoever, and that bone is actually being hurt through the arthritis process. So the other question is, why does arthritis hurt? Any questions? You doing okay? So the question is, why does arthritis hurt? Well, arthritis hurts because that bone becomes rough and exposed, and within the bone lives nerve endings. Cartilage has no nerve endings whatsoever, and that's why you don't feel your joint moving when it's normal and healthy, because there are no nerve endings within the cartilage. There are many, many nerve endings within the bone. Just, as you would know, if you break a bone, you know it. So those nerve endings transmit pain and irritation to the brain, basically. And as that cartilage becomes thin and the bone becomes exposed, those nerve endings are rubbing against each other and causing pain signal to the brain. And that's why arthritis hurts a lot. So could it be something else? It's not infrequent that patients come to me in the clinic and they think, I have a hip problem, when it really turns out to be something else. So the other things that it could be would be like low back pain. If you have pain in this region, that's typically associated with low back muscles. It could be an SI joint, things like that. That would be treated with physical therapy, potentially an injection, anti-inflammatories, other conservative management, which we would be happy to initiate and then transfer your care to the definitive specialist for that particular problem. Another thing it could be is bursitis. If you have pain on the outside of your hip, kind of like where the holster would sit if you were an old-time cowboy, that pain is typically coming from bursitis. So bursas are on the outside of joints and they allow translation of the skin. If you have very significant tenderness in this region, when you push on it, likely that is resulting from bursitis. That can be improved with Voltaren cream, anti-inflammatories, physical therapy, stretching, and potentially a cortisone injection, which we would be happy to help you out with. If you have a pinched nerve, you can have pain that runs past your hip, even through your buttock, down into your thigh, all the way into your foot sometimes. And that can be the result of a pinched nerve in your back. So patients get arthritis in their lumbar spine. That arthritis puts tension and pressure on a nerve, and that nerve is turned on in the brain. The brain doesn't know where the nerve is being turned on. It could be in the back, could be in the hip, could be in the leg. It just knows that pain signals are being sent up to our receiving center. So typically patients with a pinched nerve will have associated numbness or tingling in their foot or their leg or their thigh. It will feel kind of like a pins and needles sensation. Typically this is also treated with anti-inflammatories, physical therapy. If that doesn't work, then typically we'll get an MRI to localize the exact region where that nerve is being pinched, and then you would be seen by a subspecialty partner specializing in injections in the lumbar spine to help ease the irritation on that nerve. If that doesn't work, then there would be surgery with a back specialist or a back surgeon to help relieve the irritation on the nerve itself. Hip arthritis, lastly, the thing that I like and care about the most is actually pain in the groin. So it's very actually important that hip arthritis is manifest as pain within the groin. And you would be surprised how many patients come in and they say, man, I thought it was a pulled muscle, and then we get an x-ray and they have terrible arthritis. That's because the pain from the ball and socket joint is actually manifest within the groin. And that's because the ball and socket joint is a lot closer to the groin than to the buttock. In the buttock region, there's lots and lots of muscle and padding. So the brain perceives hip arthritis in the groin. So to evaluate, various types of arthritis in the hip, this is more mild arthritis. That cartilage is still present. There's slight bone spur formation. A patient with an x-ray like this would have symptoms like, usually they would walk with an unaffected gait. They would still be pretty active. They would have sporadic groin pain associated with certain range of motion, and they would have minimal quality of life disruption or decrease for that reason. So the treatment options for mild arthritis would be activity changes, Tylenol, NSAIDs, ibuprofen, physical therapy, weight optimization. Moving on to moderate arthritis, that ball is coming closer to the socket, the tread on the tire is wearing thinner, and that cartilage is becoming thinner. So on this particular x-ray in that region, you see the bone spurs are getting larger. This patient would probably walk with a mildly affected gait. They would have modified their activities because they figured out what hurts the hip and what doesn't, and they would stick with what doesn't. They would have, therefore, a moderate quality of life disruption because they probably couldn't do everything they wanted to do, but they could do, most basic things like walking and getting around and doing their, basic, what they call activities of daily living. The treatment options for moderate arthritis would be physical therapy, anti-inflammatories like a meloxicam or Celebrex type medication, Tylenol. You could also consider a steroid injection, which would be done with ultrasound guidance to make sure that the medicine is going right in between the ball and socket there. You would also potentially be considering utilizing a cane at this point because you want to offload some of the stress of the joint of the ball and socket by using additional support. You would also want to focus on weight optimization. By decreasing the weight of the patient, you decrease the stress within the ball and socket joint. And I always tell patients that every pound you lose ahead of the surgery is like 4 pounds that you don't have to rehab, because it will make your life much, much, much easier after surgery. For severe arthritis, when that ball is rubbing on the socket, this patient would have a very severely affected gait and walking. They would have limited endurance, meaning they couldn't really walk for as long as they would really like to. They might even feel some episodes of instability, like the hip is catching and then they kind of have to almost fall and catch themselves. And therefore, they would have a really severe quality of life disruption. The treatment options in this scenario is when the ball is touching the socket, really the only thing to do is to fix it, to fix the structural problem with a structural solution, which is a hip replacement. You could potentially consider a repeat injection if timing wasn't great for that particular patient, to kick the can down the road a few months or even a year, maybe if you're lucky, simply because the circumstances of their life at that particular moment are not conducive to, taking time off from work, from having the surgical procedure, from having support around. There are various factors that we take into account when we sign someone up for surgery, and sometimes those have to be optimized. You could also consider using a cane or a walker, again, to offload the joint. You could continue taking anti-inflammatories to help reduce the pain. It wouldn't eliminate the pain completely, but it would help improve it. So that takes us to, what is a hip replacement? So this is what a hip replacement looks like. Basically, we're taking the ball and socket, we're removing the damaged bone, the damaged ball and the damaged socket, and we're giving the patient a new ball and a new socket. That ball sits on top of what's called a femoral stem. It goes down inside of the femur. I like to kind of explain it like a fence post. At the top of the fence post sits the new ceramic ball. That ceramic ball sits inside of a polyethylene shell. You can think of the white polyethylene as like a space-age plastic. And that is what your new artificial cartilage is. So the ball can rotate around on the polyethylene and cause essentially no pain, no friction, and establish really excellent range of motion. You can see that this metal cup also has a rough surface on it, just like this femoral stem that goes inside of the bone. That's because that material is specially created and 3D printed so that the bone will actually grow onto those metal components over 6 to 8 weeks following surgery. That means that the metal components actually become part of your body during the healing process, and they integrate into the anatomy itself. So now that takes us to one of my favorite topics, which is direct anterior hip replacement. You may have heard of that. If you've done any research on hip replacement, you've heard of direct anterior hip replacement. That's my favorite way to do surgery. I do it every time I possibly can, which is about 95 to 98% of the time. There are very rare circumstances where you have to do posterior hip replacement, which I don't, choose to. Say, for example, if the patient came to me, they had a prior surgery already done through a posterior approach. Generally speaking, that surgery has to be done through a posterior approach. But basically, an anterior approach is the incision is placed in the right where the bikini line would go, or right below it, actually. Sometimes we make a unique decision based on each patient's anatomy. Sometimes it will best heal if that incision is oriented vertically, and sometimes it would heal best if it's oriented horizontally. So each patient is slightly different. You can make that preference known in the clinic, but generally speaking, we make that choice based on what's best for that patient and is going to heal the fastest. But in general, direct anterior hip replacements are putting an incision right below where the bikini would go. This is in stark contrast to what's called traditional posterior hip approach. I like to refer to this as like, grandma and grandpa's hip replacement, basically. Everybody's seen those big incisions that start in the buttock, then go all the way down to the part of halfway down the thigh. That's more so like traditional hip replacement, which we don't do very often anymore. The reason that direct anterior hip replacement is so special is that, in contrast to posterior hip replacement, this is an MRI cross-sectional slice of the ball and socket anatomy, right where we're working when we do the hip replacement. So this is the ball, this is the socket, this is all the muscles in the posterior or buttock region and soft tissue padding. These are all the muscles that are in the anterior aspect of the hip. And one defining feature is that when you do posterior hip surgery, you have to go through all of this muscle and release quite a bit of it to get down to the ball and socket. I mean, you can just feel kind of in the buttock region, you can feel how much muscle and soft tissue is there between you and the bone. And all of that has to be released to get down to the ball and socket and fix it. That is in stark contrast to the newer anterior hip replacement, which utilizes what's called the direct anterior interval. So you can even see this space right here that travels all the way from the skin all the way down to the ball and socket joint. We take advantage of that, what's called direct anterior interval, by performing surgery through it, meaning we don't have to release any muscle. We simply spread the muscles apart with retractors, almost like a theater curtain. We fix the ball and socket, we take the retractors out, and those muscles come right back together at the end. It's actually quite amazing. And I remember the first time seeing it and thought, oh my goodness, this is a game changer. So it enables us to fix the ball and socket with essentially no muscle disruption, and it's done in a very, very safe fashion. And what that results in is faster recovery for the patient. As you can imagine, if there's less muscle disruption or essentially no muscle disruption, that results in a faster recovery. It results in also increased stability. So if you're disrupting less soft tissue and less stabilizing structures of the hip, it just makes sense that inherently an anterior hip replacement is more stable than a posterior hip replacement. And that's been demonstrated in almost every literature that's examined the topic. That means that for my patients and for patients that have anterior hip replacements, there are no precautions following hip replacement surgery, which is a much more pleasant experience for the patient. They can just go live life, initiate their recovery. They don't have to be constantly worried about what they can and can't do during their recovery period. And that's because anterior hip replacements have a reduced dislocation rate for all the reasons that we discussed. There's more built-in inherent stability to the joint. It also results in much reduced risk of postoperative limp. So that simply is because there's essentially no muscle disruption, and it means when you've made it through your recovery, you should be walking very, very closely, if not exactly, basically the way you were prior to surgery. And that's the goal, is to have a strong hip that you can walk confidently on and, participate in all the activities that you love. It also means that we have much more accurate means of equalizing the leg length, and I'll explain that a bit more. But when you compare posterior hip replacements to anterior hip replacements, hands down, anterior hip replacement is much, much, much more capable of recreating the normal anatomy and the normal leg length for this patient, which is important for their ability to walk and perform activities. It also means a smaller incision, as you can see. You just need less of an incision when you're going through a direct anterior approach as compared to the posterior approach, where there's a lot of soft tissue to go through before you get to the ball and socket, which results in a smaller incision. If you put all these things together, it equals improved patient satisfaction for the patient, and I love doing surgery this way. So here's an animation or a depiction of what's called a direct anterior approach position, and then a more traditional approach to the hip. So when we're doing direct anterior surgery, the patient is laying flat on their back, and the incision is placed here in the groin region. When people are having traditional posterior hip replacements, they have to lay on their side so they can have access to the buttock region, make the incision over that region. And you can see, it's just a much more neutral position to have the body in, laying flat on your back, or what we call supine, in a relaxed position. It means that we have access to both legs. We can easily palpate all these structures and compare leg length. It also means that we have ease of access for live digital fluoroscopy, which I'll show you what that is in just 1 second. But it results in a much more accurate and reproducible of the patient's natural anatomy during the procedure. And that's because when a patient is laying on their side, it's very difficult to have access to the anatomy and the structures on the contralateral side. Therefore, you don't have comparison. And that is why anterior hip replacements are much more accurately recreating the patient's natural anatomy. So here's what live digital or direct fluoroscopy looks like. It's an X-ray machine attached to what's called a C-arm. It's brought in on the opposite side of the surgeon. So if we were replacing this patient's right hip, I would be standing here. The X-ray would come in from the other side and be taking snapshots of every single part of the procedure, and I'll show you what that looks like in a second. But it means that we have an extreme level of accuracy when we're placing anterior hip replacements, which I'm very thankful for. So this is an example of a surgery that I did where I'm placing the cup or the ball portion you can see that this is a excellent image depicting the pelvis, the femur. It's showing us all of the anatomic relationships that are necessary for the surgeon to make excellent decision making, to optimize this patient's hardware placement. So that's us placing the cup. Then we place trial components. We evaluate the patient's leg length. We ensure that by trialing various sizes and millimeter changes, we're getting the leg length exactly perfect, which is what you can see here. If you draw a bar across the bottom of the patient's pelvis, this is called the ischial tuberosity. That's what you sit on. If this line is level and we're comparing the replaced side to the non-replaced side, that bar is intersecting the femur at exactly the same point. That tells us that the right hip, which we're replacing here, is exactly the same leg length as the left, which is very important for walking. You need to have equal leg length, otherwise you would be off balance. Moving forward, we're evaluating the hardware position and the position of the stem within the femur by rotating it back and forth, which is an extremely powerful tool for the surgeon to make sure that they're placing exactly the right size component for this patient. Here's an example of the picture that we get after the hardware is placed. Again, we confirm that all of the anatomic relationships are perfectly dialed in for this patient, and we're examining the stem placement as well to make sure that that is perfect for them as well. So on top of that, what Kevin alluded to is something that we're adding on top of this live digital fluoroscopy, which is robotics and AI software navigation. So there's multiple options that are available. There's Mako, there's OrthoGrid, there's Velis. These are the three main players in total hip replacement, the top three companies in the world for hip replacement, and we work with all three. And when you have your surgical consultation, we will decide exactly the best one for your particular hip replacement. But for an example here, this is the AI software analyzing the live digital fluoroscopy image. This particular software is called OrthoGrid. It was developed on over 1 million joint replacements. And you may have heard stories of AI's, software packages analyzing EKGs and predicting changes in heart rhythm, much more accurately than the eyeball of a cardiologist, or AI software packages that are analyzing scans from a radiologist and able to predict the presence of cancer with a much more accurate fashion than a normal radiologist would be able to. So that's the same type of technology that we're using in hip replacement now, where this AI software package has been trained on over 1 million hip replacements. It's crunched all of those fluoroscopic image data and then correlated that with the ultimate leg length offset and natural anatomy recreation for the outcome of all of those 1 million patients. So it's bringing that level of expertise and translating that hindsight into foresight for us as we're making surgical decisions for our patients. So the most important thing about hip replacement in my mind when I'm performing these surgeries is what's called leg length and offset. And those are the numbers that tell me if I'm recreating this patient's anatomy accurately. And it tells me if that patient will feel good when they get up and walk, if that hip will feel natural for them. And that's our ultimate goal, is to get a hip that feels natural and enables them to do everything that they want to do. And that's what this software is, crunching the numbers for us and predicting these values for us down to a single millimeter of accuracy. It is a really powerful tool, and I feel thankful that we get to use them every day. Through an anterior hip replacement, this is a particular patient of mine where they had horrible arthritis of this hip. We went in, we took out the old ball, we took out the old socket, and we gave them a new artificial hip reconstruction. They were able to get up and walk immediately following surgery and did very, very well. So you take a hip that's totally worn out, where the ball is grinding on the socket. You create a hip where the bones are insulated from each other. They never have an opportunity to rub or contact each other or cause problems in the future. So when we're done with the operation, this is another recent technological advancement, which is what's called knotless surgical closure. So under a microscope, this is what the suture looks like. When you look at it with your eyeball, it really almost looks like fishing line, really. But what it's doing is holding onto that tissue and putting it exactly where we need it to be to heal quickly and heal strongly with regards to the incision. All of our incisions are closed in a multiple layer fashion. So starting all the way very close to the bone, all the way up to the superficial layer of the skin, there are 5 different layers that we utilize in closure, and all of them are closed with what's called knotless or self-healing suture. This suture is dissolvable, meaning the body will break it down over the next 3 to 6 months following surgery, and your body will simply get rid of it. So after the incision is closed, we use a barrier layer. It's called a perineo. This is a mesh layer that is then covered in glue, and that will sit on the surface layer of the skin and basically, isolate the internal environment from anything external. Additional to that is we put on what's called a Meplex or Aquacel dressing. This is another barrier, another way that we protect our surgical site from anything in the outside world. So many patients would ask, like, can I shower following surgery? Yes, you can. This is what the Meplex dressing looks like. It's totally sealed around the perimeter. I do recommend trying to avoid spraying water directly on the bandage because it can cause it to peel up around the edge. If you're at all worried about the dressing becoming saturated, you could always send your surgical team a picture, or you could come in and we could change the bandage for you. But generally, yes, showering is totally fine following surgery, but do try to cover it with a towel or use a directional shower head to just avoid spraying water directly on the bandage. And showering is fine, but anything submerging the surgical site would not be acceptable, like a bath or a hot tub, lake, river, beach, anything like that. Should I see drainage on my bandage? Sometimes you may. In rare circumstances, you will see a small area of drainage on the bandage. This is normal. It's part of the healing process. You don't have to worry about it. You can notify your surgical team, but generally we'll just observe it. You can leave your bandage on. You don't have to do anything with your bandage. We will take it off in the clinic and we'll handle it from there. So this is what a normal amount of drainage would look like. An abnormal amount of drainage would be one that saturates widthwise. You can see the entire width of this bandage is saturated. That's abnormal. I would like to hear about that. I would like to be notified if that occurs so that we can change the bandage and address anything we need to. Can I cross my legs after hip surgery? Yes, as we discussed, there are no precautions following anterior hip replacement. So the things you've heard about for traditional grandma-grandpa type hip replacements, like don't cross your legs, don't bend over, don't sleep on your side, use a raised toilet seat or use a high chair. All of those are related to posterior hip replacements, which are generally not what we perform on a routine basis anymore. Anterior hip replacements have no limitations, no precautions. I generally tell my patients, if it doesn't hurt, go right ahead. If your hip feels like it doesn't want to move a particular direction, just take a step back and keep going on with normal activities. But anything that feels okay and feels fine and doesn't cause pain, you can move forward with that. So in order to prepare for surgery, what I always recommend patients to do, all the studies have shown that the stronger you are before surgery, the stronger you are after surgery, and the faster and better your ultimate recovery is. So I always recommend patients initiating what's called prehab, meaning we start exercising and getting the body strong prior to the surgery even occurring. The best way to do that is by taking gravity out of the equation and performing an exercise here, what's called a straight leg raise. So if you can imagine laying flat on a bed or a couch or on the floor, and someone's hand is about 2.5 feet in front of your toes, and you have to kick their hand about 60 times. If you do that twice in a day, once in the morning and once at night, that's going to strengthen your quadricep muscle, your hip flexors, and your core. Those are all the muscles that we need to be tuned up and strong for you to walk and stand up and hit the ground running with your recovery. And if that becomes easy, you could always add an ankle weight, but if you can do that 2 or 3 times in a day, you will be profoundly happy that you did, and your recovery will be much smoother. Another exercise you could consider for surgery is called a half squat. So don't go all the way down. You don't have to go to 90 degrees or below. You just go down a little bit, about halfway, and then you come back up. If you need additional support, you could hold on to a bar or a chair in front of you, and that will really strengthen your quadricep muscles quite significantly ahead of surgery and means that you will recover faster. If this exercise is too difficult, you could always just focus on the straight leg raise. Some patients with arthritis simply can't tolerate this range of motion and this stress on the joint, so focus on the straight leg raise if that's the case. Can I go home the same day of surgery? Yes, the vast majority of our patients go home the same day of surgery. Somewhere about 80 to 90% of our patients actually leave the facility the same day we do their operation. It's called same-day surgery discharge. It's a wonderful experience and generally results in the best and most optimal outcome for that patient. So the patients that generally can't go home after surgery, and this is not a hard, fast rule, this is not set in stone, but these are general guidelines, and this is a decision that you would make discussing with your surgical team. So anyone with an age greater than 80 generally is recommended to stay overnight. Any cardiac, pulmonary, or renal history or chronic medical conditions, those patients may want to stay overnight for observation, not for the hip for any purposes, but actually just to keep an eye on those chronic medical conditions and make sure that nothing has changed with regards to those. Any diabetes with an A1C above 7.5 means that the blood sugar is not as tightly controlled as we would like, and that means you might need to stay in the hospital to observe that blood sugar and making sure that it's appropriately controlled. Any inability to ambulate, so if a patient is in a wheelchair or really heavily relying on a walker prior to surgery, that means that they might not clear PT evaluation and be able to be discharged from the facility. So those patients may want to think about staying overnight in the hospital one night. Anyone that has had a serious stroke or mild, a heart attack within the last 2 years, any significant cardiopulmonary incident within the last 2 years, generally speaking, need to be in the hospital one night for observation. And we would always coordinate with your subspecialty partner, so either your cardiologist or your pulmonologist. We would discuss with them directly what they feel is the safest way to do this surgery. Any history of a bleeding or anemia, that means that we need closer observation of you for at least 24 hours following surgery to make sure that you're safe. Another question we get all the time is, how long do I need to be off of work? So it's a personalized decision, actually. I've had patients that are self-employed that work from home, that do desk type work, and they had surgery on a Friday and they went back to work on a Monday. I don't recommend that personally. Even for people that do desk work, I would recommend taking about 3 to 4 weeks off of work. Keeping in mind that when you do go back to work at 3 to 4 weeks, you might still have some swelling, some pain. You might need some ibuprofen, Tylenol. You'll probably have to take frequent breaks and elevate the leg and ice it to assist with those symptoms, which are likely still present at that time. If you have a job that requires prolonged standing, so someone that works in like sales or as a teacher or has to walk around a campus or a facility all day long, I would recommend waiting like 6 to 8 weeks, because up until that time, standing for a long period of time can be quite uncomfortable. Think about it like a sprained ankle. If you stood up on a sprained ankle and walked around all day, that would result in a lot of swelling and a lot of pain by the end of the day. So at about 6 to 8 weeks, that's when patients are then able to tolerate that constant standing for long periods of time without, very significant discomfort. If you have a heavy physical job, like working in a factory, or you work in a prison, or you're in landscaping, or you're in construction, I recommend taking approximately 12 weeks off. And the reason is that all of those quick stabilizer muscles that you'll need to pivot and bend and lift and exert significant physical effort, those take about 3 months to be fully tuned up and balanced following a major hip or knee replacement. So this is the general recovery timeline that I expect for my patients. So as soon as you wake up from surgery, we're going to hand you a walker and we're going to say, yep, go do some laps around the recovery unit. At first, your endurance is going to be low and you'll be able to tackle stores like CVS or Walgreens. That's about the limit of your endurance at that time. You will undergo physical therapy, and 3 to 5 weeks after surgery, you will switch to a cane. That switch process from a walker to a cane will be done under the guidance and supervision of a physical therapist. But by the week 3 to 5 mark after surgery, you should be using a walking stick or a cane, and you should be able to walk around a Target or Walmart approximately. You'll do more physical therapy after about 6 to 8 weeks. Hopefully you'll get rid of the cane altogether, as long as that cane is not necessary for some other reason other than the joint that was replaced. After about 6 to 8 weeks, you should be able to walk almost as much as you want. So that means, hitting up Costco or Sam's Club at that point. In total, patients ask me how many times I'm going to see physical therapy. You'll see them twice a week at least for about 6 to 8 weeks. That's kind of the average. So that comes out to about 12 to 16 visits throughout the entire recovery process. So this is another way that we express that data, basically showing that during the initial recovery phase, you do have pain and swelling that gradually decreases over time, and your endurance and stamina will gradually increase over time. So say, for example, within the first week or so, you may have days that are, in the pain level of 6 to 8 range. But by the end of the first week, you should be down into the 4 to 6 pain range. And then by week 4, you should be in the 2 to 5 pain range. So it does, each week will get better and better. In terms of your endurance, immediately following surgery, you will be going for short, frequent walks because your endurance is somewhat decreased. But by the 6 to 8 week mark, you should be hitting about 80 to 90% of your preoperative endurance and stamina. So the thing that I think is most challenging for patients after hip or knee replacement is that it's a balancing act. So the things that we want to focus on, like certain activities, cause swelling. And then the other side of the balancing act is how we treat that swelling. So things like focusing on activity or range of motion or stretching, walking, standing for long periods of time, strengthening those muscles, all of those things resulted in increased swelling. So then on the other side of the scale, we need rest. We need elevation, we need icing, we need pain control, we need compression, we need a mindfulness regimen to help deal with any discomfort. So that's the balancing act that we're asking patients to undergo during their post-operative recovery process. And everyone finds out the recipe and the equation that works best for them. So bruising and numbness is a question that we get a lot about. So bruising is totally normal, totally expected following a large joint replacement such as a hip or knee. It's not uncommon to have bruising such as this. It can appear anywhere in the first 2 to 3 weeks following surgery. Even if you had no bruising for a week and then it shows up, that's totally normal. It can happen. And that bruising can show up anywhere from your belly button all the way down to your toes. And that's because as you're laying or as you're standing, that fluid and drainage will be pulled into different areas of the body and show up as bruising. Numbness is a very common part of the recovery process, especially in the anterolateral aspect of the thigh. The reason is that those sensory fibers that detect the sensation of the skin in that region, they go through your groin and they go from your belly button out towards the outside of the thigh where that gun holster would rest if you're a cowboy. So when you have an incision in the groin region, those sensory nerves need to regenerate following surgery, and that's why numbness is totally normal and totally expected for anywhere from 3 to 6, sometimes all the way up to 12 months in this region, and it will gradually resolve with time. As that numbness is resolving, you may feel little pins and needles as those nerve fibers are putting out little feelers to figure out which direction they're going to go. They are very, very sensitive. So having an intense feeling of sensitivity in this region following hip replacement is very, very normal. It's called hyperesthesia. And sometimes things like a sheet or your clothes or just a light touch will result in a very intense sensation. It's called hyperesthesia. Totally normal part of the healing process, not anything to be worried about. It can be addressed with lidocaine patches or Salonpas patches in those regions if you find that bothersome. In terms of swelling, we expect swelling in the region of the hip replacement or the knee replacement. Like I said, anywhere from 3 to 6, even all the way up to 12 months in rare circumstances. So swelling generally is episodic. It's associated with activity like physical therapy or long periods of standing. It's totally normal. It is not anything to be worried about. It can be improved with elevation and time. So that takes us to our next point, which is elevation. It's a critical part of the recovery process, and most people actually get this wrong. So this is a perfect depiction of the best way to elevate your extremity. You want your ankle higher than your knee, higher than your hip. You want everything in a straight line, almost like a waterfall of fluid running from your furthest extremity to your most proximal extremity. And what that's doing is taking the power of gravity and driving that fluid back from the swollen regions into your main circulatory system. So this is the perfect way to elevate. You want 3 or 4 pillows underneath your calf or your ankle. Now here is the perfect way not to do it. This is the best way to result in more pain and more swelling. So you do not want to bend in the knee because, as you can see, gravity then will be pulling fluid down to your foot and your ankle. So generally speaking, you do not want any bend in your knee when you're elevating your extremity following a joint replacement. That would result in suboptimal outcomes. So an ice machine is something that can be very effective in helping this balancing act between swelling and reducing that swelling. These ice machines, unfortunately, are not paid for by insurance companies, generally speaking. You can get it from a medical supply store or online. Generally, they run from $130 to about $200. I do recommend it most significantly for knee replacements, but hip replacements can be very helpful as well. Do I need someone to stay with me following surgery? So yes, generally speaking, you do want a support person present following your hip or knee replacement. It might not be as long as you think. Generally we recommend 2 to 7 days. Some people have done it alone. I don't recommend that because you really need to be planned out and dialed in for every logistical challenge you will face if you're doing it alone. But generally speaking, you need a support person for anywhere from 2 to 7 days. That's for things like grocery shopping, cooking, maybe a little bit of help with assistance of, getting around the house, getting to your follow-up appointments, and also your physical therapy appointments because you won't be able to drive right following surgery. Those are kind of the biggest things that you need assistance with. And I do recommend identifying and outlining those people in your life and discussing it with them prior to surgery. So that's our next question. When can I drive? So generally speaking, it's a complex decision following joint replacement when you're going to initiate driving again. It's usually about 2 to 7 weeks following surgery. The things, you should discuss that with your surgical care team because it's an important decision. You generally have to be off of all pain medicine, and what that means is tramadol and oxycodone. Things like Advil, Levi, ibuprofen are totally fine. But while you're driving, you can't be on tramadol, oxycodone, or any prescription strength narcotic pain medicine. You can take that prescription strength medicine at night or following your PT session, but just not while you're driving. Your response time of getting from the gas to the brake needs to be normalized to your preoperative response time. You need full sensation in that foot so you can feel the pedal and know exactly where your foot is in relation to it. And you need to be able to put full pressure on that pedal without any consideration for pain or discomfort in your replaced extremity. Can I go to rehab after joint replacement? So many patients ask us that, and they think that they want to go to rehab, but it's generally not needed after a knee or hip replacement. And the reason is that rehabs these days are designed for patients that are very, very sick. So patients that had a stroke or a heart attack, or they had sepsis, or something like that. And those rehabs are geared towards those needs. So even patients that we have that have had a knee or hip replacement and they end up going to rehab, a lot of times they just say, how fast can I get out of here? Because I'm really not enjoying this experience. So generally, patients that have a hip or knee replacement don't need to go to rehab. Outpatient physical therapy is the best way to recover from your hip or knee replacement and do it the fastest. The reason is that when you go to a rehab, like I said, those are geared around patients that are very, very sick. And the rehab intensity at a rehab it's not very high. So if you go to an outpatient physical therapist, they're used to dealing with hip and knee replacement patients, and they will accelerate your recovery process. So rehab authorization is based on the post-operative PT evaluation, meaning that unfortunately the joint replacement surgeon has no control over whether or not you go to a rehab and whether your insurance pays for it, because it's based on your physical capability following the hip replacement or the knee replacement. And that's how insurance companies determine medical necessity. So they're not going to pay for anything that they don't think is medically necessary. That determination is made by the physical therapy evaluation following your joint replacement. So quickly, we'll discuss some pain control here. So the most advanced pain control strategies following joint replacement involve a multi-tiered pain control strategy called multimodal pain control. The first tier is generally Tylenol and ibuprofen. The second tier is tramadol. And then the third tier is oxycodone. So tramadol is a nice halfway step between the over-the-counter medication and the more heavy-duty pain medicine like oxycodone. Tramadol is much less habit-forming. It's much less likely to make you somnolent or sleepy, and generally is a much safer medication. And if you understand this kind of tier, you understand that if you cannot take anti-inflammatories or NSAIDs for any particular reason, like ibuprofen, this balancing act with this multi-tier pain control regimen can be more difficult. So if you can't take NSAIDs, you need to get really dialed in and really focused on swelling control. So things like elevation, ice, mindfulness, meditation, frequent breaks, anything you can do to help decrease pain and swelling without anti-inflammatories is something you're going to have to focus on. So here's a more detailed outline of that protocol. Tylenol or ibuprofen, which is 1,000 milligrams of Tylenol. I recommend taking that on a scheduled basis for the first 3 days following surgery. Again, ibuprofen is 600 milligrams. I recommend taking that on a scheduled basis, meaning on the clock for the first 3 days. Then you have your tier 2, which is tramadol, either 1 or 2 tablets. You take that based on your need, based on your pain level. Wait an hour, do some icing, some elevation, practice some mindfulness or meditation, see how you feel. If you still have more pain, you can take the backup oxycodone pain medicine, either 1 or 2 tablets based on your prescription and your pain level, but only if necessary. And then after the first 3 days, well, generally speaking, also, you want to limit Tylenol and ibuprofen to a maximum of 3 doses. And then tramadol and oxycodone will be every 4 to 6 hours at most. And then after the first 3 days, Tylenol and ibuprofen can be converted to like an as-needed prescription. So here's an example of a particular patient's day-to-day pain control regimen. They wake up at 9, they take an ibuprofen. 3 hours later, they take a Tylenol at noon. 3 hours later, they take an ibuprofen. 3 hours later, they take a Tylenol. And then at nighttime, they take an ibuprofen. Generally speaking, you want to take ibuprofen either with a meal or a snack. So that's why it's centered around those times. This particular patient went for a walk, and after they came back from the walk, they had more pain, obviously. So they took a tramadol, either 1 or 2 tablets, around 10 a.m. And then they had a PT session later that afternoon. They preemptively took tramadol prior to their physical therapy. And then after physical therapy, they had pain that didn't go away with all the measures that we discussed. So they took some oxycodone after that. So this is an example of kind of a generalized timeline or an example of how to schedule your pain medicines so that they're optimally timed, alternating ibuprofen and Tylenol every 3 hours, then working in tramadol as needed, then working in oxycodone as needed. That's generally what we recommend, and it's the most successful pain control strategy. So just a couple things to wrap up here. When to wean off of your pain medicine. This is specifically related to tramadol and oxycodone. So it's a gradual process. It should begin at 2 weeks following surgery. There are sometimes that you do physical therapy and you really just need pain medicine, even beyond 2 weeks, beyond 6 to 8 weeks. It's just as needed. Sometimes patients have pain at night that they need to treat with tramadol or oxycodone, and you should because you need to sleep and recover. And then I would kind of use 6 to 8 weeks as a period to begin what we call hard stop. So only after following an extreme PT session would I recommend taking any high level of prescription strength medicine after the 6 to 8 week mark. When can I fly? Quickly, so within 3 to 4 weeks following surgery, you could consider domestic flights. 6 to 8 weeks would be international flights. You generally want to continue your blood thinner or DVT prophylaxis all the way until you come back from your trip. Even 2 weeks after your trip is when I would recommend stopping it. You want to monitor for symptoms of a blood clot or pulmonary embolism. You want to use preventative measures like compression stockings, staying elevated, doing ankle pumps. And then if you have any history related to a history of DVT or PE, you should avoid travel for 12 weeks following surgery. If you need a letter regarding assistance in the airport, either a golf cart or a wheelchair, anything like that you think is necessary, alert your surgical team and we can help coordinate that. Do I need a card when I go through TSA? No, you do not. No card is needed at this time. You simply notify the agent of the scanner. They will allow you to go through. The scanner may beep. You don't need to show them your incision or anything like that. They see this all day, every day, because hip and knee replacement is very common. So sleep. You should initiate the optimization of your sleep and recovery prior to the operation 3 to 4 weeks ahead of time. You should focus on sleep hygiene, which is everything that happens around the time of sleep, when you get in bed, when you wake up. All of those things need to be outlined, and you have to stick to the schedule in order to optimize your sleep. You can focus on mindfulness and meditation. You can go on YouTube and find examples of those for 20 minutes, 15 minutes, 30 minutes to help relax your mind at night or focus in the morning. You should pay careful attention to your controlled, pain management schedules. You should discuss sleep with your primary care physician to see if you need anything to help optimize your sleep. The things that really have been shown to optimize sleep after joint replacement are spinal anesthesia and going home after surgery. You can utilize sleep aids like melatonin or Ambien or Zolpidem. You should discuss that with your doctor. So the last thing I will say is that you should focus on the light at the end of the tunnel. The first several weeks after hip or knee replacement can be challenging and difficult. You can question your decision to undergo that operation, but I always joke at the 2-week post-op appointment that we will be friends again soon. It's only a matter of time until things get better. Knee and hip replacement would not be as ubiquitous and common in our society if patients remained as unhappy as they are in the first several weeks. And that we did this to regain your physical function, your ability to walk, your ability to do what you love for the rest of your life and be pain-free. So that's my talk. Thank you guys very much. And now we'll open it up to questions.
All right, Brittany, why don't you kick us off, and we'll see if Dr. Lingamfelter can make one more cowboy analogy.
Yeah.
Okay, so just some of the questions that have come in that I felt would be beneficial for you to answer. The first one is, how is the arthritic bone cut out and removed?
Absolutely. So that's performed with what we call an osteotomy, but it's a very precise cut made within the bone, and utilizing what's called an oscillating saw, we remove that particular bone. So it's actually a saw that the surgeon is controlling. And, everybody says, like, don't go into an orthopedic surgeon's operating room because it looks like Black and Decker, like a like a mechanic shop. But basically, it's performed with a very precise saw, and it creates what's called an osteotomy. And that's how we remove the bone.
Okay, a couple more patient-specific questions, but there's one person who said they've had 2 hip replacements. Last one in 2016. The second one resulted in ossification in the muscle mass,
Yes.
experiencing limited mobility. So is there anything he could do at this point?
Oh, absolutely. Yeah. So they're referring to a very rare condition. It's called heterotopic ossification. It occurs in less than 1% of hip or knee replacement patients. It's where the muscle actually becomes irritated and starts forming bone in regions that you wouldn't expect it to or you wouldn't want it to. Yes, there is absolutely something you can do for that. You take bone scans, so you're determining the level of activity of that bone formation. As soon as that bone formation stops, you can simply remove that heterotopic ossification through a surgical procedure, and then you use adjunctive measures to help reduce the risk of that occurring again.
Thank you. Another specific question, why would a person have a large hip joint effusion and pseudotumor within a year of a hip replacement?
Great question. So that is another very rare occurrence. Pseudotumor generally is referring to fluid that is accumulated around the hip. The most common reason that patients have a recurrent effusion and pseudotumor formation is actually what's called metal on metal. So back in the 90s and 80s, they had this concept of a metal ball on a metal cup, and they thought that that would make it more long lasting. But what it ended up doing is it generated these metal particles. Unfortunately, I never put in a metal on metal hip replacement, but I see them in the clinic, and we evaluate their pseudotumor with an MRI. If it becomes necessary, we simply go in and we take out the metal articulation and we put in a modern metal on polyethylene or ceramic on polyethylene to help eliminate the formation of pseudotumor. The other potential reason why a patient might have pseudotumor is if the joint is not particularly balanced well, or for some particular reason, that polyethylene, that plastic component, is wearing out faster than we would expect it to. It can generate particles, and that particle formation can result in pseudotumor formation. So that's less likely, but it is possible. Again, that occurs in very, very rare circumstances.
A lot of questions coming in about steps after having a hip replaced. Can you address that for us?
Yeah. Oh, stairs. Yes. Okay.
Yes.
Great question. Thank you. So stairs, what I recommend is that, first of all, you will be able to do stairs. You will use the unaffected joint, the joint that did not have surgery. That foot will go up, and then the operated foot will come up after it. So you will take stairs like one at a time, basically. And by doing that, you can tackle almost as many stairs as you want to right away. I would recommend minimizing the amount of stairs that you have to tackle the first day of the operation, but I have had patients that lived in a second floor apartment and they had to make it up 2 flights of stairs and they did fine. So in those circumstances, you go slow, you take breaks, you have someone there supporting you just in case it's needed. But generally speaking, if you have a bedroom on the second floor, see if you can sleep somewhere on the first floor. If you have a couch or a futon or somewhere to sleep, and somewhere to use the bathroom, you can stay on the floor. That helps minimize the number of stairs that you have to do initially. But within the first week, you should be able to handle whatever stairs are necessary. You can also minimize the number of stairs by staying with a family member who has a home that has minimal stairs. You could also, I've had patients consider staying in a hotel for 2 or 3 days following joint replacement because you're just going to take the elevator and hang out in the hotel. So generally speaking, you are able to do stairs. You want to take strategies to help avoid and minimize the number of stairs, but you will be able to do it.
Thank you. I know it sounds daunting, but If you have this surgery done at a hospital versus the surgery center, who will work with physical therapy the same day, even if you're going home from the hospital the same day of your surgery, physical therapy will work with you and practice stairs so that you know the correct and the safe way to do so.
Yeah.
Another question, Dr. Max, if you could do a brief overview of a posterior replacement. It sounds like some patients have had posterior replacements in the past and would need another one. So would it have to be posterior approach again?
That's a great question. So it's not absolutely necessary that you do a posterior hip replacement the second time around, even if it was done the first time. It's just something that we evaluate in the clinic and we figure out the best way and safest way to do it and accomplish our goal with minimal risk. So posterior hip replacement, it's a larger incision. You have to go through the IT band, and then you have to release what are called the short external rotators. So those are some of the stabilizer muscles of your hip. And that's why essentially it's a little bit less stable than an anterior hip replacement, where you don't have to release those or open up the IT band. So it just means that it's a little bit slower recovery. Generally speaking, you'll probably get to about the same level, but that's the long and short of a posterior hip replacement.
That was all of the outstanding questions in the Q&A. So,
awesome.
Kevin?
Yeah, I just want to thank you. Dr. Lingamfelter, do you want to put up your contact information one more time?
Yeah, absolutely.
And then in the chat, everyone, I put a great quick read on same-day joint replacement surgery, and how it's possible. And that all came from a great article by Dr. Lingamfelter. And then I just want to remind everybody, Dr. Lingamfelter joined last year alongside a few other joint replacement surgeons at the same time that we also renovated a phenomenal surgery center here in Fairfax, just across the street from Inova Fairfax Hospital. So if you watch on inova.org, there's a joint replacement video. I'll put that link for our joint replacement page in the chat, and you'll notice this great video. Everything taken from within clinic is real deal. That's right there. We've got incredible tech, but it's really just the great patient waiting areas, the great patient rooms, wide open spaces. So it's a lovely place. And I think a great place for not only recovery, but for surgery. So you can take a look there. Dr. Lingamfelter, anything you want to leave us with, parting notes?
No, I just thank everybody for their time. Thank you very much for watching. Thank you for attending. I look forward to discussing with everybody regarding their hip or knee replacement. I feel, like Kevin said, I feel very fortunate to be within the Inova system because we have absolutely the best facilities, the best technology, the best staff around to help ensure our patients feel supported at every aspect of their joint replacement.
I agree. And I guess the one last thing I wanted to add, just a reminder, everybody, you will be sent a video recording this within a week. And if you have any comments or anything, feel free to reach out. I can even put my email in here, but I think my phone number was part of class registration. So if you have any issues, please feel free to reach out. And again, Dr. Lingamfelter's information is here, 571-414, and I just missed the last four numbers.
There you go.
There we are, 6940. So make sure you guys write that down. And if not, again, we will send a recording and you can watch the whole thing over again as well. So thank you, Dr. Lingamfelter. Thank you, Brittany and Romina. Everyone have a wonderful night. Appreciate your time.
Thank you guys so much. Have a wonderful night.